Welcome back, everyone. Today we are diving into something that sounds incredibly dry on paper, fascial planes, but is actually the secret highway system of the human body. Dr. Sarah, I'm pumped because if you don't understand these layers, you're basically flying blind in the ER when an infection starts moving.
Exactly, Dr. Khan. While students often just want to memorize the names of the muscles, the boards love to test the spaces between them. For our listeners, remember, fascia isn't just stuffing. It's organized, it's predictable, and it determines where a disease process goes next. Let's start with the basics: superficial versus deep.
Right. Think of the superficial fascia like a fluffy, padded wetsuit just under your skin. It's got your fat, your cutaneous nerves, and those tiny blood vessels. But the deep fascia? That's the real deal. It's like a series of tight internal envelopes or shrink wrap that keeps muscles in their own little compartments. Sarah, why does that shrink wrap matter for the exam?
It matters because deep fascia is relatively inelastic. On a board exam, if they describe a patient with a crush injury and a limb that is rock hard with no pulse, they are testing your knowledge of fascial compartments and compartment syndrome. The fascia doesn't stretch, so the pressure builds up and shuts down the blood flow.
Boom. Clinical relevance right there. But let's move to the neck because that's where the fascia really acts like a GPS for bacteria. I always tell my residents that the neck isn't just one big tube, it's a bunch of smaller tubes wrapped in layers. If you have a patient with a nasty tooth infection, it doesn't just stay in the mouth, it follows the path of least resistance.
And that path is defined by the deep cervical fascia. High yield point here. There are three main layers you must know: the investing layer, the pretracheal layer, and the prevertebral layer. The investing layer is like a collar. It surrounds everything. But the pretracheal layer is specific. It only covers the front of the neck, the trachea, esophagus, and thyroid.
Okay, so here's the clinical why. Imagine you're the doctor of choice in a rural clinic and a patient comes in with a perforated esophagus or a deep neck infection. If that infection gets behind the pretracheal layer, where is it going, Sarah?
It's going straight down into the thorax, specifically the superior mediastinum. Because the pretracheal fascia blends with the fibrous pericardium of the heart, an infection in the neck can literally become an infection around the heart. That is a classic second-order question on step 1.
It's like a basement flood. If the pipes burst from the second floor, the neck, and there's no floorboards to stop it, it's going all the way to the basement, the chest. And we have to talk about the most dangerous one, the retropharyngeal space. This is the danger space, right?
Technically, the retropharyngeal space is between the buccopharyngeal fascia and the prevertebral fascia. For the boards, keep it simple. It's a potential space. It's usually filled with loose areolar tissue, which is basically an open invitation for an abscess to spread. If you see a lateral x-ray of a child with a widened prevertebral soft tissue shadow, you should be thinking retropharyngeal abscess.
And the reason we sweat that is because that space extends all the way down into the posterior mediastinum. You can go from a sore throat to a life-threatening mediastinosis in a heartbeat because that fascial plane provides a frictionless slide for the pus. It's a literal anatomical slide.
Precision is key here. The prevertebral layer is also significant because it fixes the vertebrae in place, but also provides a base for the axillary sheath. If you're doing a nerve block for arm surgery, you're injecting into a space created by that fascia. If you miss the plane, the block doesn't work.
Exactly. Anatomy is destiny in surgery. Let's pivot slightly to the skin and fascia connection. The book mentions how the dermis is thinner in women than men and how it's connected to the deep fascia by those fibrous bands. I think of these bands like the studs in a wall holding the drywall to the frame. Why does this matter clinically? Think of burns or skin grafting. That's a great lead-in. For the exam, understand split thickness versus full thickness grafts. A split thickness graft takes the epidermis and part of the dermis, leaving the sweat glands and hair follicles behind. Why? Because those appendages are deep in the superficial fascia and act as islands of regeneration. They help the donor site heal. It's nature's backup plan. If you don't burn past the basement, the fascia, the skin can still rebuild from those deep roots. But once you destroy those fascial layers and the appendages within them, you're looking at significant scarring and the need for full-thickness grafts.
Let's wrap this up with a high-yield summary. If you see a question about an infection spreading from the head and neck to the chest, look for fascial planes or mediastinitis in the answer. Know your three layers: investing, pretracheal, and prevertebral.
And remember, fascia isn't just a divider, it's a conductor. It directs the flow of infection, defines the limits of a surgeon's reach, and explains why a simple neck abscess is a medical emergency. Anatomy is never just about names, it's about the path. Great chatting with you, Sarah.
You too, Con. Study hard, everyone. Those fascial layers are the lines in the sand for the body's defenses.